Good evening, ladies and gentlemen. Welcome to the inaugural webinar of the Pain Association's quarterly webinar series. I'm Dr. Ong Se Yang, the president of the association, and I will be your moderator this evening. The association will be organizing quarterly webinars to promote knowledge sharing, and as a value add, we have decided to make this webinar series free for our members. We are revamping our association website and will soon receive an updated look. Meanwhile, I welcome members and pain-interested healthcare professionals to follow us on our social media sites for updates of our upcoming events. Today's webinar is titled Telehealth in Pain Management, and we are honored to be collaborating with the Singapore Psychological Society. The COVID-19 pandemic has pushed telehealth adoption to the forefront. This webinar will present a broad overview on the evidence for telehealth use, address the feasibility and practicality of leveraging on telehealth consultations in the treatment of chronic pain, and provide some suggestions on how telehealth can be implemented for chronic pain care. I encourage you to type your questions in the Q&A box as the webinar progresses, and we'll try to answer them at the end of the webinar if time permits. We have 4 speakers lined up for you. Each of them is an experienced professional in their respective fields. Dr. Singh Prit Anand is an anesthesiologist and pain physician from Changi General Hospital and the current honorary secretary of the Pain Association. Dr. Sherry Chan is a psychologist in private practice and the current president of the Singapore Psychological Society. Ms. Wendy Ng is a physiotherapist with the Singapore Sport and Exercise Medicine Centre at Novena and a council member of the Pain Association. And last but not least, Ms. Adele Ang is a principal physiotherapist at the Phoenix Rehab and Farrer Park Rehab Centre. Our first speaker will be Dr. Singh Prit Anand. Dr. Singh is a senior consultant anesthesiologist at Changi General Hospital and a pain physician. He's trained in pain medicine in Edinburgh, UK, and completed his master's in pain management from the University of Edinburgh in 2012. His clinical interests are in pain management, regional and day surgery anesthesia. He has done much work on the subject of telehealth for pain medicine, and he's also the honorary secretary of the Pain Association. Dr. Singh, please.
Thank you very much, Seon, for that kind introduction. Good evening, everyone. I shall be sharing my screen another wee second, something we have to do for telehealth all the time while speaking to patients. Lovely. Am I visible and audible? Yes, okay. Am I visible and audible, admin?
Yes, Dr. Singh.
Okay, lovely. Thank you. So this is just a wee quote by Frank Snowden, who is a medical historian about epidemics and pandemics. And as we all know, COVID has, that's my conflicts of interest. COVID has pushed us into a sort of medical conundrum. A lot of our resources have been pushed toward intensive care societies, intensive care units, and other centers. And chronic conditions have suffered a bit, especially the non-urgent ones. However, that was a negative part of it. Positively, I think telemedicine has been picked up very quickly all across the systems, primarily by the participants and even by the governments and the systems. This is just a bit of things that have happened across most of the platforms that provide telehealth for us. We work on Zoom, and as you can see, the profits have gone up year on year as the COVID has raged on. And I'll be talking a bit about telehealth, telemedicine being an older term, challenges, advantages, how we do it, and conclusions. And if you have any questions, we'll answer at the end, or you can put in the Q&A box. Okay, so telemedicine, that has been used for, the term has been used more of a narrow term in which we're using telecoms to administer healthcare to patients in geographically disparate areas. So basically, more telephones, less videos, but only doing remote consultations. I was talking about this in Thailand a while ago, and pretty much they do a lot of telemedicine. Telehealth is up and coming, has been practiced for the past some time, good evidence for certain fields, and its delivery and facilitation of health and health-related services. So there are other things as well. They do provide medical care, consultations, examinations remotely, but they also provide education both for provider and for the patient. What we're doing today is a part of telehealth, what we call e-health. What it also entails is giving you services, information services by devices. We've got Health Buddy and Sing Health, in which we can have questionnaires, patient-related outcome measures as the patient come into the service. So that's part of it. And we also use patient monitoring systems as well. That can be done. We've got an explosion of tech everywhere, a lot of biofeedback happening to our watches, and these can be transmitted across. And that's what is up and coming, more of that in the Western hemisphere than here at the moment, but we are progressing that ways. I think that's the future of telehealth. Okay, so pre-COVID, for pain medicine per se, the whole holistic part of it, I don't think we were using much of it. It was slowly coming along, but there has been an explosion in the past year. There's been very good evidence that's going on in psychology, as Dr. Sherry Chan will talk about it. Dermatology, very good evidence. Some evidence for physiotherapy as well for use of telehealth pre-COVID. And I think Dr. Chan has got a few slides about meta-analysis that have shown decent, and so would Adele and Wendy. But what have been the challenges? Let's just talk about it for a minute before we get on. We all have been redeployed. We worked in ICU, did on-calls. We had a few consultants who'd never done on-calls in public health institutes in the century, but been redeployed to work. We've been very stressed. In fact, a new study just came out in BMJ 3 weeks ago, which said almost a third of physicians were burnt out. And I think similar study was published in Straits Times as well about medical professionals, and about 1/3 are feeling a bit burnt out. Obviously, there's a lot of physical, social distancing, not enough travel or holidays. A lot of resources were consumed as well. Clinics were converted into control centers. Non-essential appointments were stopped. Therapy was stopped, and patients, especially the chronic pain patients, felt really isolated. And some patients were quite apprehensive coming to the hospital. We reached a did not appear rate for approximately 25 to 30%. A normal not appearing rate is about 10%. During COVID last year and earlier this year, when we were termed a cluster, our DNA rate was approximately 30-35%. So patients are apprehensive catching the disease. And that's where I think telehealth comes to fore, and patients do pick it up. And the issue with chronic pain being biopsychosocial, as you can see in this slide, there's a lot of social disconnection. Pain patients anyways have a smaller circle, feel socially isolated very quickly. And that is one part. The other part of it, being socially isolated, you then stay with the family. And if family is very solicitous, you may have more flare-ups. However, family can get desensitized. You might not get enough support from them, and that becomes deleterious for you. A lot of patients feel that there's reduced access, and that's true. They weren't able to get their medications on time. We didn't have deliveries last year. So this formed a part of a lot of stresses for them. There has been increase in domestic violence over the last year, in fact, interpersonal violence as well. So things have gone on for the past year, which has caused the pain to sometimes be exacerbated, and even maintaining it on and on. But with telehealth, we've been able to bring that care towards the patient much closely, been able to deliver therapies, been able to deliver medications, and that has been a boon as well for the patients as the time has moved. And we've seen that hopefully there will be future for this as patients take this on board. So what are the categories? Usually audio, video, or even by emails. It can be synchronous, live, or it could be asynchronous, in which you can record patient vitals, record various things, and then you can transmit images, etc., via confidential medium. Or it could be consultation types. For chronic pain, physician, we don't really do first visits via telehealth. We usually do follow-ups on stable patients. However, I do understand in Washington and a couple of other places in Western US, they are doing first consultations, but then they do have a hearing interview with the patient beforehand and then pick up the patient as a follow-up from there on. Interactions-wise, as I said, can be between us people, healthcare workers, between patient and healthcare worker, or caregivers as well. We do a lot of interactions with healthcare workers and caregivers and social services via text, via email, and via audio as well. We have access at Changi to community nursing, and they're able to help us do telehealth for them. Last but not the least, I talked about the mobile health, in which we do patient questionnaires by apps, and then we do the education thing that we're doing at this point in time, which is a part of telehealth. So what are the advantages per se? We've been doing it. I'm sure a lot of us are doing it. So there are lots of factors which are advantageous to telehealth. First and foremost, you can assess the patient's mental status for where they are when they pick up a call at their home. You know how they behave at home, what's going on, what are the interpersonal interactions. between the relatives and friends. How do the relatives behave with them? Sometimes when they come to clinic, we miss that. But when you see them at their home environment, you can also see their commitment, how do they live, what their surroundings are. That can give rise to a bit of bias, which is a disadvantage. But you get to know if the patient's always on the bed all the time or trying to do something, and you get to know about their compliances and know what's going on in their lives, basically a snapshot of their lives. Convenience wise, it's quite convenient for the patients. They are turn up for the appointment, you give them a time. There's hardly any did not appear rate. Once you fix the appointments, there is no traffic, there's no parking issues, no checking in, using PPEs, coming to the hospital and going away, so on and so forth. So it's quite easy that we are saving resources, we're saving time. In fact, the organization gains a lot as well, because there's efficient delivery of care without the patient having to wait a lot of time. And sometimes you can have collaborative services. You can have a multi-D care with the patient, when two different healthcare workers can have a single meeting at two separate places via Zoom. So that works as well. Patients can be discharged after treatment, or there can be transitioning of care per se from the tertiary hospital onto the community. And if you then have a comprehensive evaluation, i.e. somebody phones up the patient, a nurse clinician, does the initial assessment, does the initial questionnaires, it comes in quite handy when you then do the remote monitoring for these patients and remote management like we do with community nursing alongside the mHealth platform. Disadvantages wise, I think the first and foremost is, can you hear me? If there is not a very good internet connection, if there's not enough high-speed data, or the patient's not very literate, as I said at the bottom, then it can be a bit of a problem. Patients sometimes, when we speak to the patient, we sometimes miss the non-verbal cues, which obviously form more than 50% of our interactions, how the patient sits, what they do. Yes, you can see them talking to you, but you miss those non-verbal cues sometimes with these patients, and that can impact for how we speak to the patient or how they behave. Okay. There is a limited ability to perform the examination for the patient. You may miss a differential diagnosis, especially if there are evolving symptoms. I would first suggest that we shouldn't be seeing these patients as telehealth. But if there's a patient who's got evolving symptoms, we sort of ask them to come to the clinic or get seen earlier in A&E. So you may miss a differential diagnosis with evolving symptoms. Okay. There might be history with psychological issues. There might be issues with privacy for the patients. They may not be very happy that everybody else in the house can listen to it. And there can sometimes be patient engagement issues in the form of distractions. I'm sure we are 20 of us. Some of us are already on the phone, and this happens quite quickly as well when you've got a patient and they may have distractions with other electronic devices or something else. Like I've got a dog at home who's coming and licking my feet at the moment. There are always distractions that can happen with patients. And if that happens, you have to be careful what you do. Now, reimbursement is another thing. I was just reading an article that came in from India and from Thailand. There are problems with payments. Sometimes patients don't have bank accounts to pay, and so on and so forth. So that can be an issue. Last but not the least is medications management, especially opioids. I would suggest that patients who are on opioids, they come and collect their medication or send their helper or someone for it. Otherwise, we do deliveries. I'm just writing Grab for the sake of it rather than Grab per se. Okay. Digital divide comes at the last part of it. And I think digital divide is one thing we have to think of. If the patient is not literate, not able to do internet connections and so on, it becomes a problem. And we have to be very careful that these patients are given the same care, maybe just via telephone rather than anything else. Okay, so what patients are appropriate? I would do stable patients whom I know, who've been to my clinic a few times, whom I know that symptoms are static, there's nothing new evolving, and they're needing more of a medications management and general hand holding. Sometimes we do see patients for coordination of referral to other services, physiotherapists or psychologists, or the patients had a scan, the scans are normal, or had other investigations, we can discuss the results, and occasionally medication management for some patient, pure medication management. These are also done by nurse clinicians. We are coming to a point now that we're going to be starting off post-procedural management in a way that the patients who've had procedures are going to be followed by the nurse clinician in 3 weeks post-procedure to see if the patients had good relief, and do post-procedural questionnaires for them to give us a sort of patient-reported outcome measures for procedures. I wouldn't really see patients in a way for red signal or a red flag, the patients who got issues with digital literacy, brand new patients to the pain clinic, or patients who got new evolving symptoms or not sure what's going on, or drug-related issues. Any aberrant behaviors, patients do not go on telehealth whatsoever. And anyways, patients major depressive disorder or major anxiety or other issues with mental health. Last but not the least, if I'm doing a consultation, find the patient is unwilling or fairly detached, I actually call them in for a face-to-face appointment within a few weeks rather than letting them wait for a standard 10 to 12 weeks. So what are the salient features? I think first and foremost is a code of conduct. It remains the same as you would do face-to-face. We have to be ethical, we have to be professional to make certain everything's on board. You need to have systems in place. I think what WHO proposed last year, which is space, staff, stuff, and system, they have to be all in place. Patients, the healthcare workers have to be trained up. There have to be facilities for everything. You need to have a room, a computing system, and enough support to do appointments. And the decision to do a teleconsult relies entirely upon us as healthcare workers. However, if the patient's not keen, I wouldn't go down the pathway of teleconsult. And I think about 20% of patients whom we offer aren't really keen. They much rather come and see, primarily because they do feel isolated, and this is a bit of an outing. And as we are coming to a sort of phase 3 again, I think we would feel a little better. Okay, so details wise, as when we start, we take an explicit consent from the patient who leaves my clinic that they'll be getting a Zoom consult the next time. And when we do it, we verify their ID, we revisit the history, do a bit of counseling as you would do, the analgesia, the affect, the drugs they're taking, the side effects, the social history, the issue sleep and everything, do a bit of counseling, a bit of pain neuroscience education again, if we feel that's required, get the prescription sorted, and tell them how it's going to be collected. Usually it's not an urgent prescription, so we give patients some extra in the previous consultations. They may have to wait for a day or two to get the prescription to their home, and the payment part is dealt with by the room assistants, not by me per se. And as I said, we are completely entitled to stop the consultation if we feel that there are any issues with telehealth. Okay, there are or can be issues with misconduct and confidentiality. I think we have to be careful what patients are chosen for this one. And any amount of inducement of patients or trying to get patients to do telehealth when they're more appropriate for face-to-face can land you in a bit of a soup. I would be very careful using any data or images of the patient, and that's a PDPA thing rather than anything else. And whatever we say or the patient says to us is confidential as it is. So I think most things that apply for face-to-face also apply for Zoom consultations. Okay, so we've talked about the audiovisual. What about audio only? I think we've got lots of patients who are a bit older, and we should offer them audio only. About 10% of my telehealth is audio only, and it provides them an equity of access. I think the patient feels that, or we feel that there's a bit less bias. We don't see what's going on in their home, and it's a little better for them. And calling and talking on phone is a natural flow of conversation. As you do between friends, you do with patients, you do the same thing as you do in AV, but only audio only, and it's equally efficient. There can still be issues of engagement. There are issues with the body language, non-visual cues. If the patient's on speaker or has a healthcare worker, there will be issues with privacy. And last but not the least, reimbursement. More often than not, I have been asked many a times, is this call going to be charged? As much as it bleeds my heart to say yes, but that's how the organizations run. And I think there has to be equity for all patients all across for telehealth. So if we were to measure up, how do they all measure up? Green is what the green signal. Face-to-face, I think we can do everything from interview, examination, observation, management, questionnaires, MDT. For audio-visual, I don't think we should be going down the pathway of new patients. That's a red flag. Almost an orange flag for medications management if they're on opioids or there's any aberrant behavior. However, for audio only, I think we can't really do any examination or do much of an observation, stroke counseling and education. And there's hardly any MDT collaboration, unfortunately, with audio only. So I'm about to finish now. I think we are still in the nascent phases of this explosion. We still have to do a lot of QA. We have to do a lot of patient-reported outcomes. We are doing patient-reported experience measure to see how they feel after the engagement, but we don't do prompts yet. And I think that's something that needs to be done. There is going to be hesitation about patient engagement post-COVID-19, like we did face 2 months ago, but we're back to same again. But I think we should be able to engage patients. Third thing being documentation, we document everything. I normally have a nursing staff, we're thankfully blessed to document what we speak, and we then get an idea. However, future research is still needed to come to a sort of best practice that we have, and then we go on. However, if we redesign the services, I think telehealth has got a major thing to play. This is a bit of evidence from literature. I think Sherry is going to talk about it as well. It has clearly shown that doing telehealth does decrease pain, disability, improves mood. There is decrease in pain interference, and there's decrease in medication as well, not to talk about cost effectiveness. Okay, so we started off in CGH last year about this time across various disciplines. We had training done. I was a departmental lead at that point in time for telehealth. We initially started with a single room where different services would come, but now we have decentralized model in a way. Most staff clinics have at least one room with Zoom, and that deals with 2 or 3 people. And admin have now been trained up to get this up and running, including how to slot patients, how they get text the day before, how they get phoned on the day, and post health as well. So in conclusion, I think it's inexpensive. It's the way forward. It avoids the risk of virus spreads. We can do a lot of health education, as you would know, as the talks are coming up. There can be some unforeseen consequences, both positive and negative. More positive, I would have hoped, rather than negative. But I think we have to take the good with a little bit of gray shades as well. And as I said, if you're going to be redesigning the services, I think telehealth should be an integral part of patient management in chronic pain. And I think we need more research and collaborations as the time goes on. That's pretty much it from me. Thank you very much. If you would like to read a few things about this, these are the resources. There are QR codes. I'm more than happy for you to click pictures and then use and see the resources, which are quite useful. That's pretty much it. Thank you.
Thank you, Dr. Singh, for a very well-rounded overview on telehealth and chronic pain care. I'll encourage everyone to type any questions they may have in the Q&A box as the webinar progresses, and we will try to get to them at the end of the webinar. Our next speaker is Dr. Sherry Chan. She is the current president of the Singapore Psychological Society. She practices as a registered clinical psychologist and supervisor at a private practice and works extensively with adolescents and adults presenting with a range of psychological and health issues. She holds various professional positions with international psychology associations and works to promote health and wellness in the community. Dr. Chan, please.
Thank you. It's been a pleasure. Let me just share my screen with everyone. Okay, so thank you very much for the very kind words. I'm very grateful for the association as well for inviting us to be a part of this. It's an interesting perspective, right? Thinking about chronic pain management as like over Zoom or over Skype. You're like thinking, Dr. Prit already mentioned that there's been a trend towards this, and some of the research has been showing some good outcomes. But today, we'll focus a lot more about, what it's like, I suppose, right, to have pain. And the mental health concepts around it and how it's kind of dealt with over a telehealth system. Does it really work? Well, we'll see. Okay. So, I think, no conflict of interest, but, I think before the heightened alert system, right, there was all this hope about, low numbers, we're doing so well, right? Things are taking an upturn. And then heightened alert happened, right, because of some of the situations that we face in Singapore. And what then resulted was the, Netflix again, when it's ever going to end, travel bubbles are a curse, right? Don't ever bring up Hong Kong, too much word, end of the world feelings, right? And just essentially a lot of stress. So before heightened alert, we're kind of happy. During heightened alert, kind of stressed, but now we've come out of it, sort of, right? Still stressed, yeah? There's people who are thinking, am I on or off this week for work? How can I manage myself better? COVID numbers are still not zero. There's still so many unlinked cases. We can't wait to go back down with the kids. All these things that I've raised are quite like, normal, what you call, right, situations and things that we would experience. But what if we had pain? Is that the same things that we experience, or is there something more to this kind of experience that we have as well? Still stress? Definitely still stress. but maybe different types of stress as well, right? You know, sitting at home is quite killing for a lot of us who, you know, who have back pain issues or, you know, many different types of pain really. I've got clients who, because exercise has been the one that has helped them to kind of release some of their muscle stress a bit, doing it at home hasn't been really the same. So what they felt was like they can't go out very often, or sitting at home is quite tiring or hard for them. You know, they're unable to function like before. Everything seems quite useless and a bit hopeless when they're just about to get themselves moving. Lockdown happens again in some ways. You know, some people have told me, I'd rather COVID than pain, because COVID seems to be a bit more, I suppose, manageable, whereas pain is like never ending and continuous for some of us here. There's a big question, right, of how can they manage themselves and how can they manage some of their family situations as well. So essentially, more stress, more pain, right? So Dr. Prit mentioned this as well. When you're feeling a lot more stress, it's a very kind of like, you know, mental health and physical health combination. The more stress that we experience, the more our pain receptors are activated in some ways, and that kind of perception shift for us as well. So a lot of pain then gets increased. So I can only imagine during this whole COVID situation, when most of us, you know, were feeling some of that stress, a lot of pain clients like yourselves here maybe, or, you know, friends that you might have or relatives, would have been feeling that extra sense of pain, both physically and in a mental health kind of way. So telehealth, right? Like, I mean, if you ask me honestly, you know, would I be doing talks on Zoom so often, or even just, you know, having this panel discussion here, or just the idea of doing telehealth and kind of like consultations, this would be me. I'll be like, huh, really? Really, must I, you know? And I wonder how now, right? When you ask me, you know, maybe 1.5 years down the road, now we are all Zoom experts, Skype experts, you know, Microsoft Team experts, every single expert that you can be, right? And the question for us is, how do we move from my sloth picture, you know, to being experts in this current field? And has it worked so far or not? This is some of the research that's come up. You know, I think in Australia especially, there's been a 50% sort of decrease in face-to-face consultations, with a similar and proportionate increase in telehealth consultations when COVID started. The number of services that increased for telehealth consults, you know, as a whole also increased. And, you know, most of the people that we noticed in an Australian context anyway, were younger than or equal to 45 years old, and most of them had more than video consults, like what Dr. Prit mentioned. Some of the older clients would just have audio consults or phone consults, so to speak. And there were lower utilizations for individuals that were more than or equal to 65. And this kind of makes sense also because of the lack of maybe the IT or the technology that we have at home, or, you know, the savviness that we have as well. What's interesting though, in a Singapore context, right, you also notice that in Singapore itself, there's this absolute increase in demand for telehealth kind of services, right? We've had one of the highest relative search volumes, meaning that people who searched out for telehealth options within our area and region in East Asia, they call it. Singapore is one of the highest compared to maybe, I think, 50 countries that they raised. So we were maybe about 38 out of 50. And we have a really good infocom structure to support this, right? So as you know, most of our government sectors as well are pushing very hard for the introduction and implementation of, you know, telehealth. So when COVID started, right, public healthcare institutions stepped up. You know, we had, you know, IMH and Ng Teng Fong, and every single hospital that I personally worked in before as well, that started to kind of push for telehealth services, both for psychological appointments as much as any of the medical consults that have been mentioned before. And MOH, right, is going to license telemedicine in mid-2022, and they're also asking us as associations, you know, what is it that we need? You know, how do we make sure, right, that telehealth services are safe for you guys to use? How do we make sure that we get the best out of the client doctor interaction as well? Because, you know, it's a bit difficult, right? It's not really the same as if we were to be speaking right in front of, you know, everyone here tonight as well. So question here, right, is kind of like how effective has this been in the realm of chronic pain, right? And what exactly do practitioners need to look out for when we're using telehealth services for pain? You know, is it the same as per any of our medical conditions? Maybe, maybe not, right? Are there some things that we need to kind of take a bit more care about if we're talking about pain? So closer to home, in Singapore itself, there's been a lot of digital tele-reviews for patients with abdominal pain. So it was a telephone-based like review versus a digital review. Digital review had data that was meant to be input beforehand. So it's kind of those like apps, right, where you kind of input data beforehand so that before you see a doctor, the doctor is able to get a sense of what your statistics are and what are some of the requirements that you may need and stuff like that just before your video consult. And what this led to was actually a lower representation to the A&E department of a certain hospital. So there's some benefit in the use of telehealth services when it comes to pain. There's also been conversational AI kind of chatbots. So in Singapore, I think this has been kind of slowly being tested out, if I'm not wrong, but this research has also been tested out quite a bit in Germany, where there's been this like a bit of an app again, where you do a messaging system with an AI kind of chatbot that can reply you, or initiates conversations with you like, hey, how are you doing today? And then you have options to choose from, yes, no, good, bad, or, a pain score 0 to 10, right? Can you rate your pain score for me today? Have you done this particular activity or exercise? And then you're meant to kind of click some of these like pre-existing buttons and answers. So what they've realized is that, there's been a lot of chatbots for mental health as well. And in Singapore, this is what has been done, right? Where there's apps like, I think some of the health apps where, it's an online system, but you also can message a chatbot and then there'll be sort of replies back and forth to determine, right, whether there's any severity of the mental health issue before then being kind of referred on to the actual psychologist, for example. So a lot of these chatbots right now also provide a lot of advice. So a bit more psychoeducation wise to some of our hospital clients. This has been found to be quite effective and quite, I guess, different, right, in a way of providing or provision of information, especially if it's online. You can access it anytime. It's kind of like, own time, own target. You don't need like a case manager, for example, to sit in front of you. So that's where some of the differences lie. I'm not sure if it's too small, but if it is, in Singapore itself, we do have quite a few different modes, like Dr. Prim mentioned as well. So I won't go through them in all, but essentially these are some of the things that, we or studies have been trying to find out a bit more about when it comes to chronic pain and telehealth. Things like, e-health, where, there's a bit of a program that people just run, or even virtual reality or augmented reality. These two kind of video reality styles are kind of still being incorporated into like the mental health kind of field. So for example, right now we have use of virtual reality for clients who have dementia, and kind of like getting them to kind of see like, some of the old scenes, for example, and walking them through some of their old habits or old places that they visited before, a bit like reminiscent therapy, so to speak. We've also had virtual reality for phobias. So for example, having like a screen that, shows a height phobia, for example. So you're walking on this tightrope, for example. And in the pain realm, I've not kind of read so many, but I can imagine that, this could also be something that we could use, in future when it comes to chronic pain and the use of such virtual reality styles for telehealth. So generally, I would say that because, COVID is still, well, it's not old, it's not new, but it's been quite a while. Unfortunately, right, because of that, and because only when COVID and pandemics happen, then there's been this great push for telehealth services. Unfortunately, the research is not that great. So what we have so far is that we have some effectiveness. It's not fully effective. There's not like great big sizes, but yet there's this trend. So, for clients 21 to 79 years old with lower back pain, they were provided intervention. There were small to medium effects over 3-month follow-ups. A lot of the related health outcomes and back-related disability were targeted rather than the pain intensity itself. So a lot of the times when you feel pain, you don't just feel pain, right? You also feel a lot of the distress or the anxiety or the depression, maybe low moods, right, that come with it. You feel a lot of the loss and the grief. And what we notice is that the telehealth portion of that is what really helps some of these clients with some of these kind of related health conditions. There's been a study done on children and adolescents. So, does it only work for adults? What about kids, right? Not super big, I suppose, follow-up studies just yet. So this is still kind of in the works. There's been one study that suggested a beneficial impact on reducing headache severity, but overall, there isn't very clear beneficial effects just yet. So this could still be another realm, right, or area to kind of discuss and research more upon. What's been interesting though, is that there's group pain management. And in a group setting, like a CBT online versus an in-person setting, there was actually similar benefit. And I can get the sense of how group settings, right, could be quite helpful on like a Zoom platform or any telehealth platform as well. So interesting there. So I think one of the ways that telehealth has been used in a better sort of way, if I may say, right, is in conjunction with some of the face-to-face consultations. So some studies have suggested that when it's used in adjunctive pain care after completion of in-person CBT, it resulted in a reduction of medication use and kind of increased the health outcomes of these clients. When it was used in adjunct to internet self-management after standard pain treatment, so after face-to-face kind of consults as well, there were better psychosocial outcomes for clients with fibromyalgia. So there is this sense though that research is still scarce, but it's quite promising. It has its benefits in managing pain, though only for some clients, and some of the things that Dr. Craig mentioned earlier as well. However, I think one thing to note for psychotherapy or for psychology in particular, right? CBT seems to be the most commonly employed technique for pain, but more than that, is most commonly employed in a video or telehealth kind of platform as well. So it is effective for the depression, anxiety, stress symptoms that actually come and accompany individuals who have chronic pain. So it kind of has a small impact on reducing the pain disability itself, but as we all know here, right, our physical pain and our mental health kind of come quite well together. So that's where I think most of the research, or I suppose some of the support, can be found. So as I sort of wind down into sort of my last few slides and conclusion, I will say that there has been some benefit, right? So it definitely, sometimes telehealth gives us some home information, meaning that when you're at a client's home, you can see their backgrounds, you can see how they sit, you can see where they are at, what are some of the other activities that they're doing. So it kind of provides an observation of other home behaviors as well, which can be very helpful for, let's say, in a psychological setting. Instead of going to a home visit, which sometimes we do, we might just use a video conference and get them to kind of show us their rooms or show us what their living conditions are like, so you can understand some of their mental health status better. There's also convenience, right? Improved access for sure, like what's been mentioned. A lot of flexibility for our clients. So sometimes, if let's say they're only able to take time off work or in the middle of the day, these kind of telehealth appointments can be quite helpful for some of the clients that I've seen, where they just take 1 hour out of their day, right? And then they can just go back into the work zone again. Don't always recommend that, but sometimes it's helpful for them. I'd rather them come, right, than miss due to work commitments as well. So, it also fills the gap. I guess telehealth consults can also fill the gap, and it helps a lot with case management because it allows you to kind of maybe see more clients as well in different settings. So that's kind of quite helpful in an overall as a well-being kind of way. Of course, there's cost, right? So we're not going to lie about it. There's definitely going to be cost in some of these things as well. So it's hard to read non-verbal cues. I'll talk a bit more about that when I share a case to end my presentation today. There's a lot of distractions that can happen, right? Noise, kids, dog, right? There's just a lot of distractions that could happen in the process of telehealth. There could be a lack of privacy issues as well. So it's a bit difficult to always ensure that you have a safe, quiet environment like what some of us might have the privilege of having. And essentially, right, it doesn't work if you're not particularly tech savvy. So that's also something that as we grow and learn as well, how can we help make sure, right, that our population keeps up to some of these trends and these IT stuff too. Okay, so would you use telehealth? Would I use telehealth? I mean, my answer is yes and no. For a mental health setting, I think it's important that the client's emotionally stable. So even as they have pain, right, are they kind of emotionally present and stable such that they don't kind of maybe have moments of breakdowns or meltdowns where I can't do anything over the screen? Will it help increase the accessibility of the client? So if the client is going to be able to come rather than not come, yes, I'll use it. Are there other mental health issues together with the pain, like what I mentioned before? So, yes, then some of these telehealth services could be quite helpful also. Not just Zoom or consults, right, but also like apps to monitor pain or to check kind of activity levels or to monitor mood, all these things can be incorporated, right, into this whole setup. But of course, if the client has high needs, they don't have insight into their problems, or they have no privacy, easily distracted, then I may not then use telehealth per se. So maybe just to conclude my presentation today, maybe I just share a client that, I've seen this client for a couple of times since January till now. In fact, I just discharged her this afternoon, which I was really kind of thankful for. She came because of pain issues that she had. She has this like nagging pain in her abdomen area, endometriosis kind of stuff, and she has this shooting pains across her body. And we did a bit of combined work. So we kind of saw her in session, but we also did some video consults. And this kind of process was, I didn't know whether it would work, but with this whole process with her, it kind of worked quite well. We managed to do a bit of CBT stuff over Zoom sessions. We kind of also managed to kind of work through some of the coping styles and thought processes, how to challenge some of those thought processes when it came to pain as well. And I found that the telehealth system was not any different really from being face-to-face in terms of the skills. But what felt different was, of course, the presence, right? So it felt different because I couldn't feel her presence in the room, and I needed to ask more questions as well to make sure that I could catch the gestures properly, or to even catch the facial expressions properly. And I felt like that was what was different. But overall, I think a combination was quite helpful. And yeah, I mean, personally, I'm also looking forward to see how this grows, and to see how, as psychologists, we could also adapt to what new technology is out there as well. So thank you for your time. And this is, yeah, thank you for having me here today too.
Thank you, Dr. Chan, for the engaging presentation. Our next speaker is Ms. Wendy Ng. She's a musculoskeletal physiotherapist at the Singapore Sport and Exercise Medicine Center at Novena, with a focus on chronic and complex musculoskeletal pain, and is a current PhD candidate and Australian Government Research Training Program Scholarship recipient with Curtin University. Wendy is also a council member of the Pain Association of Singapore. Ms. Wendy Ng, please.
Okay, let me just share my screen. All right. Okay, now, thank you for the introduction, Se-Yang, and thank you for having me here. So good evening, everyone. My name is Wendy. So I will now give you a physiotherapist's perspective to telehealth in pain management. And I'll be co-presenting this segment together with Adele. Okay, so now I have no conflict of interest to declare regarding this topic. Okay, so before I begin formally, it will be good to let everyone know that I'll be talking about telehealth and musculoskeletal pain management in the context where I practice. Okay, so the suggestions put forth in this presentation will be applicable to private practices or musculoskeletal outpatient settings with a strong focus on treating mainly adult musculoskeletal pain. So where I practice, at Singapore Sports and Exercise Medicine Center, Novena, we can see patients as a primary care musculoskeletal provider, meaning I am the first point of contact for a patient with a musculoskeletal health concern. And I also can see patients as a secondary care practitioner, meaning we get the referrals from doctors, okay, with a known diagnosis. Yeah. So the suggestions for the patient selection criteria of telehealth are designed with having to do our own screening for red and yellow flags in mind. Okay, so these are the targeted categories of conditions that can be managed via telehealth. So for subacute musculoskeletal pain, the patient must be on the trajectory of recovery. So that means it doesn't warrant a recheck on their differential diagnosis. Sufficiently confident to self-manage, like their exercises at home as well. And they must be comfortable with taking advice from a healthcare professional using video consultation. So video consultation will be the mode of telehealth treatment we are talking about here, okay? Now, for chronic musculoskeletal pain, the patient's pain and other associated symptoms must be stable, and they require ongoing advice on exercise progression, and prescription, as well as some reassurance, okay? Similarly, the patient must be comfortable with the concept of self-management and taking advice using video consultation. For post-orthopedic surgery rehabilitation, now telehealth is suitable from the subacute phase of recovery, whereby the patient's pain and swelling is already well managed, and that the patient only requires advice on exercise progression and prescription. So for this group, video consult will not be suitable for patients who requires things like manual therapy or soft tissue work to treat their movement impairments and range of motions deficits. Post-fracture rehabilitation. Okay, so telehealth is suitable for patients who only requires advice on exercise progression and prescription. So similarly for this group, video consult will not be suitable for patients who requires any form of manual therapy work or soft tissue work to treat stiffness, tightness, and range of motion deficits. Now for acute musculoskeletal pain, I would say telehealth must be used with great care for this group of patients, especially on initial consultation. Okay, so video consults may serve to fulfill the subjective assessment or patient interview portion of the overall physiotherapy consultation, which may then warrant a face-to-face session in the clinic for the objective assessment, as well as any other additional checks for us to formulate a diagnosis. So the main idea is this. Now, physiotherapists should exercise discretion and independent judgment while taking into account the principle of patient safety always, okay, when deciding whether or not a video consultation alone will suffice to manage the condition. So I would say consider using a hybrid model of care, meaning like video consult plus face-to-face consultation whenever necessary. Okay, so specific patient inclusion criteria. Now, informed consent are given for the session. So good communication skills, meaning the ability of the patient to comprehend verbal instructions and to be able to express well through video consultation. They must also be comfortable with the concept of self-management, self-monitoring of their own symptoms, okay? And the patients have the necessary technical equipment, such as video camera, computer with good internet connection, as well as exercise equipment like TheraBands, free weights, or exercise mat to execute the video consultation. For specific patient exclusion criteria, now patients who are not comfortable with the concept of self-management, self-monitoring of symptoms and active treatment, as well as patients with known visual or hearing impairments or cognitive impairments, or if you're suspecting any presence of red flags, okay, telehealth will not be suitable. Now, patients who require a higher level of instruction through a combination of like visual, auditory, as well as like kinesthetic cues from the physiotherapist to learn a movement, okay, for this group, I would say that telehealth probably must be used with caution, okay. Now, patients who requires manual therapy, soft tissue work, or any other kind of specialized equipment, like such as the use of a reformer to relearn a movement, as well as if there's any clear indication of an aggravation of symptoms or distressing symptoms, okay? Now, they wouldn't be suitable for telehealth. All right, now this article here provides the clinicians performing the virtual musculoskeletal examination with a specific set of guidelines to enhance the information obtained when performing the objective examination. And this masterclass article here introduces telehealth and summarizes the current research within the context of musculoskeletal physiotherapy. So it gives suggestions to the approach to implementing telehealth into existing healthcare settings. What I just presented about all the selection criteria is adapted from here. So if you're interested to have the full text of the articles, email me. Okay, so now I'm also going to point out that there are telehealth guidelines issued by various physiotherapy associations that physiotherapists can use as resources. Telehealth may be novel in countries like Singapore, but has been around for some time in countries like, for example, Australia. So my understanding is that in Australia, there may be a lack of specialists and health services in rural areas, okay? Or accessibility of care may be limited by geographical distance. So, you know, telehealth is not new for them. It's really quite unlike Singapore, whereby we can easily travel from one place to another, okay? Now, it is really important to understand that specific restrictions may be imposed on the scope of practice if care is being delivered via telehealth. So I would say that, you know, it's good to probably refer to the telehealth guidelines issued by the association for guidance on this. It is also important that clinicians ensure that their professional indemnity insurance policies explicitly cover the provision of healthcare via telehealth within the jurisdiction that they practice in. Okay, so especially if you are to provide this service in the private sector, this is something important to take note. Okay, next. a crucial question is this: is there evidence for how effective telehealth is in musculoskeletal pain management in physiotherapy? Now, I tried searching the literature, and there is no known published data in the Singapore context yet. I'm talking about musculoskeletal pain here, okay? So I think currently there may be some initiatives like collecting or tracking data, such as the number of visits or patient experiences, like what Preet mentioned, okay, related to telehealth at the level of different hospital departments. So I'm really quite unsure about whether healthcare clusters or nationwide wise, whether anyone is tracking the effectiveness of this in a local context yet, okay? At a more global level, this is a very recent publication, so a huge review of systematic reviews. I think in the end, it included something like 53 systematic reviews in this article, okay, to summarize the available evidence of telerehabilitation in physical therapy. So what they found was that telerehabilitation in physiotherapy, specific to musculoskeletal rehabilitation, could be comparable with in-person rehabilitation or no rehabilitation to improve pain and physical function in musculoskeletal conditions such as osteoarthritis, low back pain, hip and knee replacement. So this means, good news. There is evidence that telehealth is effective for what we do in physiotherapy. Okay, now this is a 2017 publication and the very first systematic review and meta-analysis to quantify the effectiveness of telehealth-based interventions in non-specific low back pain. So 11 studies were included in the end, okay? What they found was that specific to treating chronic low back pain, compared to a control group, and I think the control group, what they meant by it is no intervention, patients are on a waiting list, or very minimal interventions such as non-health related or low back pain information, okay? Now, telehealth interventions had no significant effect on pain at the short-term follow-up. That means up to about 3 months follow-up, okay? Now, telehealth interventions had no significant effect on pain at the medium-term follow-up. So between the 3 months to the 1 year follow-up, and there's no significant effect for disability. However, interventions combining telehealth and usual care were more beneficial than usual care alone, okay? So meaning that if you want to think of it as using telehealth as an adjunct to a hybrid model of care for the chronic pain patient, this is likely going to work. Okay, now moving on, this is a very recent 2021 publication, a qualitative review that synthesizes the perceptions of people with chronic musculoskeletal pain for engaging in telehealth interventions. Okay, so now on the left-hand side here are the enablers, okay, for engaging in telehealth interventions. So in my own pace, space, and place, okay. So what they mean is that the digital environment provides a safe space allowing for an something like an exchange of information with the healthcare professional, free from stigma associated with chronic pain. And the use of multimodal strategies, okay, for information provision, such as combining video and written materials, strengthens patients' self-knowledge as well as their self-efficacy and led to their own empowerment, okay? Now, on the right-hand side here are all the barriers listed by the end users, okay, the patients, the chronic pain patients in engaging telehealth interventions. So lack of personalization, okay, leading to difficulties in building rapport is something that has been highlighted. So, one key aspect is that clinicians need to learn to interact in a way that allow patients to feel closeness at a distance if you're going to use telehealth. Now, technological challenges here, they are referring to things like poor internet connection and technical issues or reduced video conference quality that can lead to bad mood of patients. Okay, irrelevant content. What they meant is that patients could not perform the proposed exercises, or patients did not find activities useful, and the task did not fit their preferences and expectations, as well as limited digital literacy, meaning that the patients may be unfamiliar with web-based technology, so creating difficulties with navigating the intervention content. So now, if we take a step and back to think about it, it is known that the therapeutic alliance is very important in the management of chronic pain. Okay, we all know that. Yet factors such as things like that diminished sense of rapport, okay, as well as content not matching to patients' expectations can be significant barriers in telehealth consults. So now here's the question. Are there ways physiotherapists can try to manage this when using a specific telehealth strategy like video consultation, especially when our profession traditionally involves the use of our hands? We do things like manual therapy and soft tissue work to have that neurophysiological effect on pain. Okay, to answer that question, it will be useful to understand a little about the different forms of therapeutic alliance, okay? Now, there are several key elements that can determine power relations in medical consultations. So in a traditional paternalistic approach, okay, usually the goals and agenda are set by the clinician. Now, the patient's values are usually assumed by the clinician, and the clinician will assume the role as a guardian to the patient. Okay, in a consumerist patient-controlled consultation, usually the patient will set the goals and agenda. The patient's values are usually unexamined, and the physician or the clinician will assume the role as a technical consultant, so you are paid to do what the patient tells you. Whereas in a partnership approach, okay, this is a more mutual relationship between the patient as well as the clinician, okay? Usually the goals and agenda are negotiated between the two of them. The patient's value will be jointly examined between the clinician as well as the patient, and the clinician will assume the role as an advisor. So, okay, incorporation of the patient's perspective into medicine's definitions of the patient's need has been suggested as the medical paradigm of the 21st century. So what we meant by person-centered care, okay? So in order to be effective online, it is all the more important that a partnership approach that encompasses connection and communication is enacted, okay? So in conclusion, there are two key messages to take away from my presentation. Number one, there is evidence that telehealth works in pain management in musculoskeletal physiotherapy, okay? And number two, taking into account the barriers associated with telehealth, okay, I would say that the therapeutic alliance is all the more important for telehealth interventions to work. We should aim to address patients' goals and expectations, as well as communicate, build rapport with them using a partnership approach to effect behavioral change or to motivate them to engage in lifestyle changes to manage their chronic pain. So in the next segment, Adele will talk about how the use of pain coaching can help to achieve this partnership approach in pain care. Okay, so these are my email addresses if you need to contact me for the research articles. Thank you.
Thank you, Ms. Ng, for your perspective. Our last speaker is Ms. Adele Ang. She is a principal physiotherapist with over 20 years of experience. Her area of interest is in improving pain management for patients with chronic pain. She currently sees patients at Phoenix Rehab and Farrer Park Rehab Center and is an adjunct lecturer for graduate diploma in sports medicine in Nanyang Technological University. As a trained life coach, she has combined her understanding of contemporary pain science with coaching to integrate best practices of physiotherapy and pain coaching so as to provide an individualized approach in helping chronic pain patients. Ms. Adele Ang, please.
Thank you, Se-Yang, for the introduction. Good evening, everyone. So as Se-Yang said, I'm a physiotherapist for over 20 years. I was trained in the 1990s, and I was trained in a more biomedical approach for physiotherapy. So my profession at that time of training was very much a biomedical approach, and I saw or witnessed that transition to a more biopsychosocial approach. So this paradigm shift is the journey I took over the years. And on this journey, I heard a lecture given by Professor Lorimer Mosley, which most physios would know who he is. And he talked about how physiotherapists can act as coaches to help patients with persistent pain. So this piqued my interest, and I took a life coaching course, actually a series of courses, and became a trained life coach. And from there, I'm using this skill set of coaching, integrating to what I know about pain science, and then from there, start to do pain coaching with my patients. And then what happened was, of course, a pandemic happened, and then telehealth became a necessity. So today I would like to share my experience using telehealth as a platform for pain coaching. Okay, so there's no conflict of interest for me to share in this topic. What are the criteria I use for selecting patients for pain coaching using telehealth? So the first criteria is that they must have had this pain for more than 3 months, so this persistent chronic pain. That they have tried other physical interventions. The reason why I added this criterion is because I won't be able to do any sort of physical intervention with them. So they would have tried any form of physical intervention, whether it's be with a physiotherapist for chiropractic adjustments or acupuncture, any form of physical intervention. I also excluded those who have red flags. So this is either through an MRI, they've seen an orthopedic surgeon and they've cleared these red flags. Or if not, I would have asked these special questions to just check if they have any sign of infection, malignancy, or fractures. Then the last point, which every speaker did talk about, is the willingness to participate. And I find that to be very important. So I do that by talking to them. The first session is just understanding and getting to know the person, as well as telling them what pain coaching is about before we start the session. Okay, so before I talk more about what pain coaching is, I'm just going to define what exactly is coaching. So coaching is a collaborative partnership between a coach and a willing individual, and it connects at a deep personal level, their beliefs, their values, and their vision. And through a process of discovery, goal setting, and specific action steps, ultimately is to realize results. It's written there, extraordinary results. So the most important part of coaching is really that this collaborative partnership that Wendy has spoken about. And what then is pain coaching? Well, pain coaching is that, but using the physical body as the pivoting point for the conversations. With coaching, we use a lot of skills like reflective listening, affirming the patient, valuing the patient's strengths, validating their pain experience. And through all that is ideally to invoke internal motivation for them to create change, more permanent change. So as you can tell, pain coaching is a lot about deep conversations. So the telehealth itself seems to be quite an ideal platform for pain coaching. Okay, I use the iceberg model to describe further what is covered in pain coaching. So I'm sure all of you have seen versions of this iceberg model. Above the water level, you have what is visible. So that would be the behavior of the patient, maybe their facial expression when they grimace in pain, or it could be the pain experience when they narrate the experience and you hear what they say. So all these are visible, right? Then below the water level, within the iceberg, you have the internal intrinsic factors. So it could be thoughts that they have about the pain, the emotions linked to the pain, their beliefs about the condition, the pain, and all these are internal. A good example of internal factor that we commonly see is a fear avoidance belief in chronic low back pain. So this is often seen in someone who has been diagnosed with a degenerated disc, and maybe they were told that to be careful not to increase the degeneration of the disc, and by reducing their physical activity, they would protect it. So that belief itself would usually cause more inactivity and more issues and more chronic pain down the road. And external to this iceberg would be all your external factors. So it will be things like maybe your relationships with family, friends, daily hassles, the environmental factors. So a good example today would be the pandemic that you see. So it could be someone who have lost their job and have financial stress due to losing their job. And then with that, poor sleep, and then with that, increased pain perception in their day. So the coaching conversations can be anywhere or even sometimes beyond what I've written down in this iceberg. When the patients start talking, that is where the focus usually is, because that is what is of utmost concern to them. ultimately, the pivoting point is still around their pain experience. So what are the advantages and disadvantages of using telehealth for pain coaching? I've listed 4 advantages on the left, and they are all interlinked. So the first advantage is there's a stronger focus on the patient's narrative. How do we get this stronger focus? It's really on the questions, how we ask the patient, what type of questions we ask the patients. So they are open-ended questions, and they are questions that are focused on the person in the center of the conversation. A good example would be, tell me more about how this pain is affecting your work life, your family life, or how do you feel about still having this pain, after seeing so many therapists or having so much treatment done for your back? And this type of questions are very patient person-centered. Conversely, if you were to see acute pain presentations, you will ask very symptom-focused, body-focused questions like, show me where your pain is, how long can you sit before the pain gets worse? And these are very much linked to the behavior of the pain itself, very focused on the physical body of the patient and not putting the patient in the center of the conversation. So with pain coaching, we are putting the patient really right in the center on the conversation. And by doing that, you implicitly focus on bringing out the patient's motivation. The motivation comes from them understanding how their beliefs, their thoughts, their emotions, the rest of their life, how does it, contribute to their overall pain outcome that they're experiencing. And that can increase their internal motivation. The third advantage is there really is a reduction in the fix-it mentality that we see in patients with chronic pain. They're coming in expecting to be fixed with a physical treatment or physical exercise or something that we can do as a physiotherapist to change their pain, to get rid of their pain. And that kind of mentality is what we usually see, where the patient sees you as the expert and they are the recipient of your expertism. However, this type of mentality we know does not work in chronic persistent pain. Okay? And finally, I feel that the last advantage is, personally, I feel there's a lot more satisfaction in my job, being able to help patients with more permanent behavioral changes. I feel more satisfaction empowering them in this process as a pain coach with my background, understanding and experience as a physiotherapist. Okay. The 3 disadvantages I listed on the right are all linked to not being able to physically touch the patient. So that would mean assessing them through physical assessment, using your hands to give tactile cues to teach an exercise, or of course, using our hands for hands-on manual therapy work. Okay, and what are the main barriers to the use of telehealth for pain coaching in the Singaporean context? So this is my personal opinion, where I feel that patients are just not ready for this type of intervention. And I think it largely lies in the expectation that when they see a physiotherapist, they would expect a physical intervention for their chronic pain. So they won't expect a physiotherapist to come in and explore their beliefs, their thoughts, their emotions, or anything else that can contribute to that pain. And that is not part of what they expect us to do. And culturally, I feel that in the bigger overall society, the biomedical model is just still more accepted, and psychosocial approaches within that biopsychosocial framework is still not widely accepted here. Okay, and I think this is my last slide. So I would like to share what lessons I've learned through pain coaching. So as I said earlier, I've been a physio for over 20 years, and my training at that time was a lot about coming in, help the patient, do what you can, whether it's hands-on work, using a machine, or teaching the right exercise, or giving the right advice at the right time. And there is a lot of emphasis on what I can do to help the patient. So obviously, that is what I'm familiar with, right? So I think the biggest lesson learned is by being physically not being with that patient, by actually being physically separated from the patient, I felt that it was easier for me to be a coach, because I can't do anything really to help them at that time. So the first lesson I really learned is that their narratives are really very rich, and they're filled with opportunities for identifying barriers towards recovery. And the second thing I learned is that because there's more time spent with communicating the patient, I do feel there's a stronger alliance. So the same thing as what Wendy says about the partnership, about working with that patient and not expert versus recipient of expertism type of alliance. Okay, so it's really understanding their values, what matters to them, and addressing their concerns. And then the last thing I saw or I witnessed was that I can witness that beliefs, thoughts, and emotions are such strong influences in physical pain. So being able to affect any of this and seeing how pain changes with this was probably a very big lesson for me to learn as well. Yeah. So at the end of the whole experience, I would like to actually thank my patients for trusting me in this pain coaching journey, for trusting me to go through it with them, because it was as new for me as it, of course, is for them, and to helping me learn these lessons that I shared. So this is the website. I have more information about pain coaching here. You can go into bodymap.com.sg or contact me on this email. Thank you for your time.
Thank you, Ms. Ang, for that unique perspective on pain coaching, and also to all the speakers for presenting a well-rounded view on telehealth in so many aspects of chronic pain care. So now we have come to the end of the webinar, and we're now at the Q&A segment. We have about 5 to 10 minutes of Q&A time. So please type any questions you have into the Q&A box, and we'll try to answer them. And also there's also a link to the feedback form on the chat box. So for those of you who have no questions, we'll encourage you to fill out the survey form so that we can improve on our future webinars. Okay, let me see if there are any questions. Okay, so I think I'll start the ball rolling since there are no questions in the Q&A box yet. Maybe I'll just direct this to any one of the panel of speakers. Is there an optimal way to schedule teleconsults in a busy clinic setting? For example, do you try to schedule all the teleconsults at the start of the day and then the inpatient consult in the later half? Because I understand it can get quite disruptive to switch between the Zoom or whatever tele platform to in-person in between patients. So maybe I can ask Prit, who has led the telehealth initiative in Changi General Hospital.
Thanks for that, Sayang. We at the moment are doing this as last 2 or 3 consults. So I normally have about 10 to 11 patients in my clinic. We do 2 consults on a Friday, that's my standard day, and at the end. But we tell the patients we're going to phone between 11:30 and 12:30. So patients are told that your appointment is at 10 past 12 or half past 12, but clarify that be about an hour's gap that we'll be phoning you. And the room assistant normally calls the patient about half an hour before, saying that Dr. Singh will call you up to arrange it, because we do it by Zoom as a platform. So we switch it on, get it done in a room. The room assistant calls them half an hour before and tells them call you in 20 minutes. And they're normally on there just like a meeting today. And we get them in, speak. The room assistant speaks first, and then we carry on after identifying them and so on and so forth. But last in the session, we have been told as this increases, which may be the case, we might have a separate session altogether. Mm-hmm. It is a bit more efficient, takes a little less than a face-to-face, depending if the internet connectivity is great. Sometimes there are issues with caregivers and sometimes issues with internet connectivity, but it goes on spick and span. That's our experience so far for the past year.
So from my experience, we tend to just slot them in maybe in the first consult of the afternoon, so straight after lunch, so as to avoid clustering of patients together, especially those coming in for in-person consults. Maybe what about Sherry? Do you have how do you optimize the way you schedule your teleconsults?
Yeah, actually in a private setting, maybe not as difficult. So we don't actually see that many clients a day anyway, so it's not too hard. So currently I try to schedule my consults first thing in the morning, because it's harder for people who are working to come. So if they want a session in the morning, it's easier for them to do it online. Whereas in the afternoon, evenings, it's easier for them to come in person because it's kind of after work, after school. So that's kind of how we schedule it rather than any way else, really. So I think more for us is about which things work better for the clients. Yeah.
Okay. Maybe as a follow-on question, since Sherry, you're on the mic.
Sure.
When conducting telehealth, do you have tips for our audience as to how to bridge the screen barrier so as to better engage our patients?
Yeah. Actually, it's a super good question because I feel like I myself doing telehealth sometimes, right? I feel super distracted, to be fair. Like I kind of also want to look at other things, and I can see sometimes my clients looking at other things, so it can be quite hard. But I usually try to get them to I try to ask them more questions actually, so that they are more kind of engaged with me. And I'll also clarify like more consistently. So rather in the room, right, I might be able to see some of their gestures and it's easier to just assume. I will try not to assume over the conversation. I will try to kind of ask and clarify and kind of maybe get them to also be involved. So I like to use like the whiteboard in some of our Zoom sessions or stuff as well, so that I can write stuff, they can write stuff, and then it's a bit more engaged that way too. So that's what I think I do most of the time.
Okay, that is good. I think we should make use of digital tools as much as possible. I think the whiteboard certainly is useful. Get them to draw something, get them to illustrate something, and that would sort of focus their attention over to the teleconsult. I would imagine it would be slightly different for telehealth for the physiotherapy setting. Perhaps Wendy, would you like to just share with us how you could effectively engage a patient in a physiotherapy telehealth setting?
Right. Okay. Now, to be really honest, I'm not sure that I'm the best person to be answering this question. But then, okay, let's just put it this way. For physiotherapy-wise, a lot of what we do, okay, usually, as I mentioned, involves with the use of our hands. But in any case, it's pretty much determined by how the clinicians practice. So for example, if let's say in my approach, I spend a lot of time listening to the patient's narrative at the start first, okay, in the patient interview part, because I was trained in such a way that 70-80% of the clues comes from there in order to be able to form the diagnosis. So your objective assessment is done just to confirm what you have in mind for the diagnosis itself. Now, I would say that I guess you could definitely be doing that particular subjective assessment or patient interview part, okay, fully via telehealth, as in not just via video consultation, but sometimes, through a telephone call, asking the patient like certain things like, how did they get the injury, or how is the pain presenting, as you probably would be able to do your work. But the tricky bit really is that part whereby, let's say for example, you're supposed to demonstrate a particular movement or exercise, and you can't use your hands to be facilitating that particular movement, okay? And it really relies on how much your patient comprehend what you are saying on video in order to it really does take a high level of instructions in order for someone to be able to do that, okay? For example, you might be actually demonstrating something like a movement on how to effectively maybe bend your spine, flex your spine to actually get onto the ground. You might have to get really creative with the way you say it. Like, for example, try to imagine that you're bending down like a candy cane. Yeah. In order to give the cues there for the patient to be able to get what you're trying to say. So the verbal instructions they are giving, we have to be super mindful of that. I guess that is one big key area that I will say that physios probably requires more training and being more mindful about it. I'm not sure whether Adele will agree with what I'm saying here. Like, is that your experience as well?
Yeah, to be mindful about the cues you give them, so that they make sure you do their exercises correctly. Yes. But my experience from the pain coaching was that a lot of times, if they have more pain with exercises, what we fail to explore is actually as I've said earlier, the beliefs that they have about the movement. So if let's say flexion of the spine after 30 years is still a problem, that is usually lies underneath that a lot of fear avoidance. And if you don't address that, that is the issue. And you cannot just tell them, oh, because you're afraid, that's why it's not working. You have to actually let them talk it out until they reach a point that they're ready to listen. or they're ready to accept that yes, why is it that flexion is still an issue? Like simple flexion just to brush the teeth, for example, is an issue. That a good example is a patient I saw who goes for chiropractic adjustments for so many years, and he always felt the adjustments has helped. And we talked about how there's so much force going through the spine with the adjustments, and how is it that you bend your head forward to brush your teeth in the morning, it hurts. So he said that the reason he gave was because when he managed to get really relaxed, the person distracted, his mind is off the spine, the adjustment goes great and I have no pain. But if I'm still, if my mind is not off the spine, if somehow he didn't manage to distract me, the adjustment didn't go well and I'm still in a lot of pain. So through the narration, through the narrative, he started to realize that he was actually protecting his spine, unknowingly protecting his spine, and that didn't work. So when we talk about it, when the belief change and how to get him to protect less, then the movement just comes. Simple movements are easier.
Yes, Adele, I agree. Certainly, these kind of change management, behavior change may take a few rounds of education and reinforcing. There's some questions on the chat. Maybe there's one from Lee Kai Sing. Are there any apps that are useful for pain monitoring or physiotherapy exercise prescription that's helpful in telemed? I guess I'll direct this to both either Wendy or Adele. Are you all aware of any apps that are useful for pain monitoring or physiotherapy exercise prescription?
Generally, for exercise prescription apps, like it will be similar to the ones that are commonly used in clinics, like what's that called? I don't use it personally, but things like PhysioTrack or something like that. Well, I would say that, let's say, for example, you are demonstrating the exercise to the patient, and let's say you could provide them with some kind of guidance. Sometimes I just send a YouTube video to the patient as well. Like this is the link that you can do that particular movement as a kind of feedback or reminder on how they actually can do that particular exercise. That will help. Yeah, but I wouldn't have any specific pain monitoring or exercise prescription apps to be recommending. That's what I'm trying to say.
How about you, Adele? Do you have any apps to recommend?
Well, not apps, but you can easily find a lot of exercise online exercise library. You need to subscribe to them to be able to look at videos on exercises. So MedBridge is an example. You have a whole library of exercises there, both video form and handout form, if you want to provide on a handout. So yeah, there is a lot out there.
Okay.
For exercise prescription. Yeah.
Yep.
Wendy, you mentioned that there's sometimes difficulty in verbally describing the exercise that you want the patient to do over telehealth. Do you guys sometimes try to physically demonstrate live to them in the telehealth setting?
Well, definitely we can, within the constraint of like in front of the screen with a mat, if you can. Okay. But it can still sometimes be really challenging depending on the movement itself. So I guess it's really being as specific as possible about the instructions. And yeah, like it really differs for every single patient. But yeah, we definitely will try our best to demonstrate in front of the screen within the setting, the limited space that we are having. Yeah.
Okay, I think we'll go to the Q&A box. There's a question from Punam Pao. Do you think with the use of telehealth, it will now be easier to have a co-joint clinic, physician, psych, and physio? Co-joint clinic is a challenge for some hospitals. Comments on charges, feasibility, please. So I think Prit has answered, will be the same as a multi-healthcare worker face-to-face with help of tech. To combine charging is a way to go as possible, helps the transitioning of care. Perhaps I would just like to add on to Prit's answer. So for Alexandra Hospital, where I spent some of my time, we actually started a combined pain clinic where I sit in as a pain physician with an internal med person, either a rheumatologist or a rehab physician. Because, we all have our unique perspectives on pain. The rheumatologist is familiar with joint pains. The rehab physician is familiar with musculoskeletal pain. So it's a two physicians sit in and we see the patient. We try to give a more holistic, broad pain assessment. And also at the same time, because the rehab physician or the rheumatologist is internal med trained, at a one-stop center, we try to take care of their diabetes, their hypertension. So we have managed to transit some of these face-to-face care into a virtual care and a telehealth kind of setting. And I think the patients do appreciate the convenience, especially for those in the early morning appointments. Some of them are not able to rush down in time. There's rush hour traffic. There's kids to send to school, so on and so forth. So they've really appreciated the convenience, and I think it is a good way to go. But of course, in any multidisciplinary setup, I think cost is always an issue, especially in a public setting. And I think, well, I guess this has to be negotiated based on the benefits that the patient can potentially reap. We may, in the end, save the patient multiple hospital visits, clinic visits, and consults. So I think this has to be negotiated with each hospital.
I think that's the way forward, if possible. With redesigning of services, I think telehealth multi-one is a good thing to go, especially for patients who are stable and cannot walk. And I think that's in line with the government's decision to bring care close to the community. And this forms a vital cog in that wheel.
Okay, I think time is almost running out. Let me quickly move on to one more question. Question from Terence Quack. Thanks for the wonderful sharing. Have any of the clinicians handle a difficult acrominous consult? How may one manage a session where the patient or client may be hostile, or where concerns exist of the other party recording the session, where the clinician may have less direct control over the clinical environment? I think there are two parts to this question. How have any one of us ever managed a difficult telehealth consult? And what do we do with patients who are secretly recording the session?
So can I start?
Yes, great.
I had a patient today who was recording. There were a couple who came in this morning, and it wasn't the first or second time they came. First time they came about 3 months ago, same story. Today I asked the lady, I said, are you recording my consultation today as well? So this is after about 7 or 8 minutes when I saw the phone in the hand like this, and you turn the phone, you can see the recording part of it. And she said, yes. I said, I asked you last time as well, if you're going to be recording, please tell me. Not that I'm going to say anything different, but at least I know. And I think this is going to be normal. We've got patients who keep phones here. You can see very clearly that's the video going on, but there's hardly you can do. There are caution stickers everywhere, do not record, but you can't stop patients. So that's one thing we can't stop. We can only ask them to tell us. One, I came from a system where we used to write letters back to the patient about the whole consultation. So there's nothing to hide. Second is acrimonious. I've had about 2 teleconsults, been very acrimonious. And as I wrote back to Terence, that I just say that, you know what, I don't think it's a discretion on the healthcare worker and on the patient. If you can't manage it, you just say, I really can't help you. Would you mind coming in? I've had the patient come in the same week saying that I can't prescribe you this. And I don't think it's getting appropriate. Would you mind coming in? And give them an option that if you're not happy with my consult, please write to feedback or the official patient experience of what has happened and accordingly document it. It's very difficult to wriggle out. Unfortunately, some patients are insistent, but there is no option. We are the customer service sort of a thing, cannot fight. That's from my side. I'll let the Allied Health take over.
How about Sherry? Have you had any difficult consults over telehealth?
Not particularly difficult. I think sometimes it's more just when the clients themselves have like maybe they're not as engaged, or it's really hard to engage them. Then yes, that's what I will find more difficult. I haven't actually noticed anybody recording as of yet. Something to look forward to next time on the phone. But yeah, so I think for me it's more just the engagement piece that's been difficult. So sometimes it's harder if the clients are not very engaged, or they're very tired, or they're very distracted, then sometimes I might call them out gently on that and kind of find out what the environment's like, what's happening. Is it okay if we don't have the session today, and can we kind of like pause and have it at a different time, because I kind of want to make sure that we are present with each other and respect this time together. That will be some of the things that I would say, because at the end of the day, we want to be able to provide I guess our input at a time where they can hear us too.
Yes, certainly. I think we all want that quality interaction, and I think I echo Prit's sentiment that even a face-to-face recording, they can be, even a face-to-face consult, I think they can be secretly doing an audio recording. So I think short of just informing them that they're not allowed to record, I think there is very little we can do to enforce it. Okay, let me just check on the Q&A if there are any more questions. Okay, I think it's past 8:30 and we've managed to answer all our questions. Does any one of the speakers have any last comments? Okay, so if not, I wish everyone a good evening. And before you leave, we will appreciate if you can help us do feedback. The QR code is available now on the screen, or you can go to the link. You can click on the link on the chat box. Okay, this feedback will go a long way into helping us improve on our webinars in future, and hopefully we can bring more quality webinars for our members. So I want to thank everyone for sharing this evening with us. I want to give congratulate all the speakers for a very well-rounded talk and a very engaging webinar. Thank you, everyone, and have a pleasant evening.
Thank you.